Questions concerning the ethical permissibility of tonight's topic, the ethics of physician-assisted death, therefore require descriptors that do not sneak in prior ethical judgments about the moral acceptability of the actions under consideration. The terms suicide, killing, euthanasia, and their sort have such long social histories of embedded and implied negative moral judgment that they probably cannot be used in a truly value-neutral sense, even if we stipulate and insist that that's how they're to be understood. But like most tensions in clinical ethics, mere distinctions do not do the work of moral reasoning. Careful arguments are required, because at issue when discussing moral standards are not the terms of the language, but its meaning. Our speakers rejected the term physician-assisted dying because that refers to compassionate palliation. That's long been part of good medical care. But more importantly, it's never been ethically controversial. The controverted point is not physicians assisting with the dying process, which can take many forms, but rather their knowingly, intentionally, willingly, and deliberately bringing about the very end of the dying process, the patient's last breath that occurs at one moment rather than another later moment. Professional standard setting, to the degree it's used in medicine, is unique among the professions, and as used in this country, unique among all nations. In these United States, the private sector of medicine is regulated to a degree, but it is not controlled by the state. Physicians continue to enjoy the freedom of self-direction, and they voluntarily use standards in their own self-governance as an expression of their responsibility and their free accountability to the society which permits their professional freedom. Standards are established for entrance to medical school and residency training, for accrediting specialty programs, hospitals, care facilities, and individuals of notable accomplishment are certified by their peers and none other. Beyond these standards that can be defined with some precision are the standards of behavior and performance that make up the professional code of ethics. And beyond that, a second set of standards, a set of values by which physicians are judged by the society they seek to serve. Since the art and science of healthcare is special, society will permit that activity only by those whom it trusts, and trusts with its very life. But the patient wants more than the application of clinical knowledge and skills to her problems. She wants help or relief from her fears and concerns. And even more, she wants the assurance, the evidence, the expression of her physician's dedicated service. Physicians understand that the most compassionate act they can perform is to provide the correct diagnosis and the most effective treatment of the disease of the patient. The science of medicine and its benefits must always be evident in the action of our physicians, but science alone can never be the fulfillment of their responsibility to the patient. Physicians also have an obligation to care about the patient and his needs, and to do so with compassion. Here, our attention is extended to the humanity of the patient. Physicians then have two areas of service, their science and their compassion. If they so choose, to each of these areas they can give a still greater dimension, a dimension of proficiency. Proficiency in science is self-evident by examining the outcomes of their efforts in terms of their ability to benefit their patients. Proficiency in compassion, however, requires thoughtful consideration. The old adage, to cure sometimes, comfort frequently, and care always, presumes a personal proficiency in compassion. Just as the traditional meaning of an attending physician is to attend to be present with the patient, and never to diminish the personal importance of being present with the patient. So our speakers now will lead us on their very thoughtful journey to help us better understand how they have come to understand their own professional proficiency in both the use of medical science and in attending compassionately to their dying patients. Dr. Quill.
Thank you for inviting me back here again. I've been here once before, and I had a lovely time interacting with you all, and I'm looking forward to this interaction. I also want to thank Dr. Tomatis, who was here last time when I was here, and the others, Dr. Reitemeier and Dr. Nagelkirk, and the DeVos family for making this happen year after year. It's quite an extraordinary event nationally to have such a colloquy, yes, occurring yearly. So I'm going to say thank you to them, and I'm going to push us right forward here. And what I'm doing right now is going to present a case to you, because one of the things that we try to do what I try to do in these conversations is to keep us grounded in real clinical experience. And of course, it's not going to be an easy case, because why would I present an easy case to you? None of the cases in this area are easy. But this was a 30-year-old medical resident. He was a wonderful medical resident. He attended all the palliative care lectures, and was going into primary care when he finished. And he was about 3 months from ending his training. He developed chest pain, which got quite severe quite quickly. He went and did what many doctors would do under that circumstances. He went and got himself a chest X-ray without seeing a doctor. And it turned out in this chest X-ray he had a very large mass in his chest. So he went to see his preceptor, because he didn't have a doctor. And his preceptor, he was a good doctor, his preceptor. My resident liked him a lot, but it turned out the preceptor didn't prescribe opioids because he was worried about addiction, right? So my resident was having to make the biggest decisions of his life, and he couldn't think straight because he had 10 out of 10 pain. So he realized that at that point he needed to get a real doctor, and he went to see me. Now again, believe me, this is not something you step up to readily, a resident who's super sick. This is not an easy task for anybody, I think. It's not a task for somebody who you don't know, but this is somebody I know who's a trainee under me. But there weren't a lot of other people to step up. I referred him for a biopsy, and he was understandably overwhelmed by what was going on. To make a long story short, the biopsy showed a yolk sac tumor. Now, some of you may know about this. I really, as a primary care doctor, a palliative care doctor, yolk sac tumors are in books, but I had not had experience with them. But I looked it up, and it turns out yolk sac tumors have a 40% chance of cure. Pretty exciting, right? The only trouble is, what's the downside of a 40% chance of cure? A 60% chance you ain't going to be cured. And this man knew statistics. And so he was, I made arrangements for him to see the regional specialist in this, because it's a rare tumor. But he also wanted at the same time to explore some other things, like the what ifs. And believe me, if you had a cancer like this, you would be wondering about the what ifs. So what were his what ifs? He wanted to make sure that if he didn't respond to treatment, that he wasn't going to suffer too much. He wanted to make sure that he could have an escape if he had really bad suffering toward the very end. And he was ready to talk about these things. In fact, he needed to talk about them because they were very much big in his mind. And it might be big in your mind, and it might be big in my mind under the same circumstance. So he needed to have these things settled before he could devote himself to treatment. And the treatment was not easy. This was very aggressive chemotherapy that he was undergoing. And of course, predictably, not only he was undergoing aggressive chemotherapy, but he had every side effect that you can know. So he was in and out of the hospital a lot during chemotherapy. So I have a brief interview of him talking, which I'm hoping that we can pull up somehow with this gizmo. Let's see. All right. Now let's see.
We talked about my fears about end of life. And I told her that this was one of them, that I was going to get to this point where life was not worth living, and I really felt it. And I wasn't going to have someone there who could help me intervene or deal with that.
Had you thought about those issues before at all, or probably in an abstract sense?
Never before becoming sick, but constantly after becoming sick. It's been at the forefront of my mind, especially during the time period when we felt like this cancer that I have might be something that might not be very treatable. But even later on, when we found out the diagnosis was actually germ cell tumor, which is somewhat treatable with some degree of success. Even then, one of the most important things in my mind has been how I can maintain control even through the end of life, should this become an end of life kind of issue.
You personally, in your own conscious control, and be the person in charge? Is that
right? Exactly. I feel like I'm in the driver's seat of this body, and I want to make the decisions about what it goes through. And if I can't make those decisions, that would be one thing that would make life not worth living. But maybe more poignantly, I want even the decision to be able to decide that life is not worth living and to end my life if it comes to that point. And that's one decision I think that's often, or we don't think about as being necessarily someone's prerogative. I mean, I think most people would agree it's my prerogative, my decision whether or not to take treatment or something. But, and I think that that degree of empowerment is given to me. But I talk with my wife and my friends a lot about this, and I made it clear to them I really wanted to be empowered. If I got into an end-of-life kind of situation, to be able to judge on a day-to-day basis if I wanted to continue my life based on my whatever, my nausea, my vomiting, my fear level, and all the aggregate of all of that pain.
So I can guarantee you I did not want to be having this conversation with this man at this time, but this is what he brought to me. And this is what we're asking you to think about when you face situations like this with patients that you really care about. And I really care about this young man. So I'm going to turn it over to Bob.
So I'm also really pleased to be here and thankful, Dr. Tomatis. And I do have to say I'm a little nervous because Dr. Quill said it was the second time he was here, and that meant that he was debating someone the first time and they didn't get invited back. And so that made me worry that it was a little bit like this is like the survivors, and they didn't get invited back. And so I'm a little nervous about this, to be honest with you. So I'm going to ask you guys some questions to help me calm down a little bit. How many of you are not clinicians in any way? Okay, about a third of you. How many of you are physicians? How many of you are nurses? How many of you are social workers? Okay, how many of you are chaplains? Okay, physical therapists. I now feels like it's Family Feud, right? I'm gonna, oh good, there was a physical therapist there. Lawyers, because That'll interfere with about half my jokes. Okay. Damn. Okay. Well, we're going to try. We're going to try anyway. The other thing that I should say is that I know that this is often a point, counterpoint, and the reason we're giving you one set of slides is that Dr. Quill and I probably don't disagree except for at the margins. I haven't, as far as I know, participated in physician aid in dying, although there have been a couple of people who I've been treating and given opiates to who have died relatively suddenly, and I wouldn't be shocked or amazed if their family came to me and said that there was some intentionality in it. I don't believe that in general, if I was the philosopher king, that it would have been a public policy that I thought we should promote. On the other hand, I want to say that 20% of Americans now can participate in physician aid in dying. And to a certain extent, I think whether it's a wise public policy or not isn't the question. Because when 20% of the public can do it, it means that all of us are going to get asked about it if we're clinicians a fair amount. And the real question is, how do we think about this issue? How do we develop public policy to make it to a certain extent, and I'll argue as infrequent as possible? And how do we, when it comes up, provide the best care for those patients? So first, let's just do some definitions. Now, we agreed to call it physician-assisted death, although many people would argue that it's suicide. We stayed away from the word suicide because of, I think, its cultural norm, and because psychiatry has tried very hard for very good reason to argue that suicide is, as a clinical event, something that should be prevented. It means that the physician provides the means that the patient requests, but the patient must carry out the final act, and that potential escape is important to many. The physician's moral responsibility is thus as an accomplice, very similar to what some might argue the pharmacist's involvement is as well, and those of you who are pharmacists might want to talk about that. It's very different from voluntary active euthanasia, in which the physician provides both the means and carries out the final act. It does require the consent from a competent patient, and in the sort of both the ethics literature as well as the literature on physicians' opinions, physicians are much more reluctant. It requires the physician be present at the time of death, and it allows a response to a much wider range of suffering because it doesn't require the patient to be physically able to swallow medications. It's illegal in the United States and much more likely to be prosecuted. I want to be clear that most of our data is currently from Oregon and from Washington. My guess is in 5 years, if you invite Dr. Quill and I back, which will make me feel really a lot better, the data will be from California because of the numbers there. We should just note that a lot of people want to talk about it. 1 in 6 or 1 in 50 people talk to their physicians, and in fact, up to 70% of physicians say that patients have asked them about this. I've been asked about it as a palliative care physician and a physician who took care of HIV-positive patients a lot. The fact that people talk about it doesn't mean that people do it. In fact, very few people ultimately act on this. Even if they're given the medicine, most people don't act on it. It doesn't mean that people don't want to talk about it, much like the case that we saw. Now, I'm going to start off talking a little bit about the ethical issues, although I'm going to argue relatively quickly that if you believe in the norms that have guided physicians in end-of-life care in hospitals across the country for the last 20 years, it gets really hard to argue that physician aid in dying is unethical. The major arguments for physician aid in dying are autonomy, that is, that autonomous patients ought to get to decide what they do with their body, much again like we saw in the video. Mercy, that is, if we can decrease people's discomfort, that we should, either their physical suffering or their existential suffering. And physicians' view of non-abandonment, that we will stick with people regardless of what happens to them to the end. The real argument that I find the most convincing is the lack of difference between physician aid in dying and foregoing life-sustaining treatment. That is, I was a doctor 2 weeks ago, and I probably saw 15 patients in the ICU who decided that given where their disease was, that they wanted the machines turned off. It was pretty clear to all of us in about 5% of those cases that there was no way that they would live when you turn the machines off. We can say that we didn't intend, but it seemed to me that given we knew that when you tried to wean them within 5 minutes, in fact, often within 2 minutes that they desaturated, or I was turning an LVAD off, it seems hard to make an argument that I didn't know that they were going to die. And to say that I didn't intend it seems to place way more weight on the importance of tensionality than I think that I, in fact, and I think most philosophers, in fact, can make that weight stick. The arguments against physician aid in dying is that intentional acts to shorten a life are wrong. I think none of us believe that sort of without some caveats, because if I pulled out a gun and wanted to kill, I don't know if you guys have a carry, you have to, but I'm not going to, just to be clear, because I just flew. I couldn't take a gun. But someone could kill me if I was threatening them. That is, we do many things to intentionally shorten life, and we don't think it's morally wrong. We worry that it might scare patients and seem like we're urging them to end their life. And while that's true, I think, as a risk, it seems to me a much greater risk to the fact that almost all deaths in hospital, in fact, are planned deaths and deaths where we, in fact, turn things off. So if people are going to be scared, it seems to be they should be as scared of almost all the other things that we do in hospitals. It could undermine palliative care because of public controversy, e.g. death panels. It could lead to slippery slopes, and I'm very worried about slippery slopes, and my hope is that we'll talk about that at the end of the discussion. And some people argue that it undermines the profession, and I think the undermining the profession is largely an argument about that physicians shouldn't be involved in intentional acts that foreshorten life. There is an argument about the Catholic rule of double effect. The rule of double effect, for those of you who forget, and that would be almost all of us, is that the intent has to be good. The bad effects can be foreseen but not intended. The suffering must be severe enough to warrant the risk, and the bad effect cannot be the means to the good effect, which is often used then to not allow physician aid in dying because neither the intent is good and the bad effect, that is shortening life, cannot be means to the good effect, which is ending the suffering. Now, there are challenges to the principle of the rule of double effect. One is it's unclear how we evaluate intention and ignore the philosophy of causality. That is, we like to say that what killed the person along this sense is not turning off the ventilator, but the person's lung disease. And yet it seems to me when we are absolutely sure that turning off the ventilator will result in the death, it seems to me that we begin to have angels dancing on the heads of pins in a way that is not very philosophically satisfying. And we have the problem of things like palliative sedation, which is in fact legal, where the intent is to escape suffering, so we sedate someone so they're no longer conscious. And it seems to me that also becomes very hard to distinguish from physician aid in dying. Now, I'm going to skip this slide. We're going to come back to it. Now, given that, you would sort of suggest that I think that under some circumstances, physician aid in dying is ethical. And you'd be right. That doesn't mean that I don't think it should be as rare as humanly possible. And I think that make it as rare as humanly possible, it means that we need to do a much better job of doing palliative care. Now, I'm old enough that when I was a medical student, there was no such thing as palliative care. In fact, that's probably true of Tim, who's even older than me. There was no palliative care. And in fact, I did HIV care for 15 years. And we just called it good medicine for really sick people who are likely to die. And yet, I think that the last 20 years, the education and the awareness that, in fact, palliative care is really important is an important part of some of what you could hear that resident talking about. I was sometimes unclear how much he wanted to be in control of dying and how much he was really scared of suffering and wanted to make sure that people really did a job and that he could choose how aggressive people were in trying to treat his symptoms. And so I would argue that regardless of what your ethical view is regarding physician aid in dying, it should be as rare as possible, and so we should do a better job of doing palliative care. Now, the problem is that even though palliative care improves quality of life and decreases symptoms, as these slides show, there's still 20% of people who we don't do a great job of controlling their symptoms. Now, part of that is that we don't have very good tools. If you look at the NIH budget, less than 1% of the NIH budget is focused on pain relief. Very little of the NIH budget is focused on treating, in fact, almost any symptoms for seriously ill patients. So there are no studies, for example, that look at how to treat nausea, which is a symptom that makes my patients absolutely ballistic, except for chemotherapy-related nausea. The amount of data on any other kind of nausea is almost missing. And so if you believe in that one of our jobs is to decrease the frequency of physician aid in dying, part of what we would do is we would do a way better job of spending our money and trying to promote good palliative care. The other thing, if you believe that physician aid in dying is a cultural or societal hotspot, we would do is we would make sure that people know about other last resort options and are able to utilize those options to try to decrease physician aid in dying. Things like stopping life-sustaining treatment. I think that often doctors don't talk about it, and there's pretty good data that for example, pancreatic cancer and other kinds of cancer, there isn't a discussion that one of our options is to focus only on quality of life and not engage in treatments. Because I think that most clinicians believe in what they do, and so we often promote what we do in ways that might constitute overselling. And it's not just physicians, it's society in general. I don't know what your television ads are like, but my television ads in the city in which I live from my healthcare systems all talk about there's a miracle coming in the next 15 minutes. You just have to have the insurance that will pay for it. And so there is this worry that we don't talk in an honest way about the fact that lives are limited and that people can either not choose to have life-sustaining treatment or stop it. We don't talk about voluntarily stopping eating and drinking, and for many people who are worried, that is an option of something that they can do to give themselves control, although particularly at the beginning it's hard for people to do, and it's hard for their family to watch them do it. Things like palliative sedation, which is another option, which is somewhat controversial, but I think in many states, and in the 80% of states in which physician aid in dying is not legal, is something that doctors need to know more about and that patients and families need to have as something on the table. So that's the ethics. And yet, one of the real questions is I do a lot of teaching for palliative care physicians, and the question is clinically, what happens if someone brings it up? And I think doctors' initial reaction when someone brings it up is to say, oh, we don't do that. I'm really sorry, I don't do that. And that's bad in almost every situation. Because when a patient brings something up to me about, if I get a lot sicker, could I have something to end my life? My real job is to take a really deep breath and calm myself down and try to figure out what's going on. that is, rather than turn into yes or no, for those of you who are clinicians, my job is to sort of say, I wonder why it's coming up. And what are they asking me? And when are they asking for it? And what are the issues that lead to it? Because I have to tell you, sometimes it comes up just because people don't understand what the dying process is like, because we've medicalized the dying process and they've never seen it. So I've had people say to me, well, if I just don't want to be a vegetable for months or years. And it's sort of like, what do you mean? And we'll say, well, I just don't want to be alive for years if I'm not awake. And it's like, ooh, that isn't going to happen. I mean, tell me what's important. And once you get to not be sort of in the quality of life that you like, we'll stop a lot of the things that we do. And for most people, they'll die relatively, in days to weeks to months. And just saying that for many people, it's like, ooh, so I'm not going to be like just laying in a nursing home for years. And it's like, no. And they're like, oh, okay, because they may not know. And so rather than view this as something that makes me really uncomfortable, which I think is like other questions, like when people ask, what religion are you? Or will you pray with me? My initial job is to take a deep breath, slow myself down, and try to figure out what's the question behind the question. Are they asking me to die now? Or are they asking about it in the future? And if it's in the future, they may just be reassured that I'm going to continue to have this conversation with them. That I'm going to help them prepare and be with them. That's the non-abandonment that came up before, regardless of what happens. Because again, many people haven't thought it through. They haven't thought through, where would it happen? Would my family be involved? Would my family not be involved? So a relatively small number of people will really want to activate, and the question is, why now? And what's the issue about what happened now? And is it something that is something that's going to blip and get better, or is it going to be consistent? I need to talk to them about what they're afraid of. I need to figure out with them, what do they think death will look like? I need to have a commitment to be with them if things don't go the way they want. Sometimes what they really want is my cell phone number. No, seriously. Because they want to know, if they get stuck, who do they call? And often talking about this will then allow them to worry about more mundane matters. If they're talking about physician aid and dying now, I need to assess their competency. Because sometimes people are just really depressed. And if they're really depressed and they don't have capacity, I need to then talk to whoever their surrogate would be. I need to make sure that I've done as best I can, treated their symptoms, their suffering, and their depression, and I need to think a little bit about their social supports. I need to be aware of the legal environment. In the state of Pennsylvania, it's not legal. And I need to have people that I can talk to that will give me advice. I've had some difficult cases, and one of the things that's most reassuring to me is that I can pick up the phone and call someone who's older and wiser and smarter than me and say, hey, can I run this by you? Am I thinking about it correctly? What have I missed? So that I can get support and help. And I have to tell you, the one case where the person really stuck with the issue, in the end, when I said, I really can't do that because I really like being a doctor and it is illegal, and that patient was in fact quite kind about it and said, oh, doctor, I would never ask you to do something that would, cause you to lose your license. And we came up with another solution that may have not been the best solution for him, but he was more than okay with. Now, at the end of this, and I'm now going to turn it over to Tim, there are questions that are going to come up that are in the slippery slope angle. And I hope we have a chance to talk about, what about physician aid in dying for only existential distress? What about physician aid in dying for patients who were competent but now have lost capacity. And so they can still take their pill because they're demented, but they're really not competent anymore. How much should we have to talk to about this with all patients at a certain point, for example, when they get into hospice? Should we require a palliative care consult for everyone who wants physician aid in dying? That isn't currently the case in either Washington or Oregon or California. And what would that mean both for access and maybe for improved care? But I'm now going to turn over to Tim so he can talk a little more about the legal issues and a little bit more about what happens in other countries.
Thanks, Bob. We're really actually so close to being on the same page, but we do have some areas that we will differ, so we'll see if you guys can find them. I'm going to talk a little bit about the current state of practice. When you ask terminally ill patients about their views about this, it turns out a fair number of them will support this option in theory. And so 60% will say, yeah, I wouldn't mind having access to that, and 10% might say, yeah, I really want access for myself as an individual. I would really like to have that. So again, it speaks to the strong interest. The public support of physician aid in dying is a general idea. I wouldn't mind having access to it, but relatively few will actually really want it in earnest. A study at a Catholic hospice of 100 terminally ill patients, 17% had a strong desire for this option. Now, does that mean that they would actually activate it? Probably not, but it means that they would like to have access to it. Who are the people who are interested? They're often patients with cancer, but also patients with neurologic diseases, particularly ALS. Any of you who have patients with ALS or might know a family member, you got a lot of time to think about things when you have ALS, when you can't move around a lot, and you're worried about being in charge of yourself. People tend to be white, Western. They tend to be the haves, not the have-nots. The have-nots are not at all interested in this issue. They're interested in getting more medical treatment. That's what they want. And most have access to hospice. So it's not an alternative to hospice for them. It's because either they don't like hospice. In hospice, I'm a hospice devotee. I love hospice, but it's an acquired taste. It's not for everybody, right? And not everybody likes to be the passive being cared for all the way through. For a lot of folks, that does not have a great deal of appeal. So some data about what people who are seeking this. They're feeling weak, they're tired of dying. It's not that often actual severe, overwhelming physical symptoms when people are wanting this. So it's really much more existential, psychosocial issues than untreated pain. And pain, as Bob was saying, is our best case scenario. We can actually relieve almost all pain, particularly if people are willing to let us give them doses that might make them sleepy at the very end. Most of the time, good pain management prolongs life. It's only rarely at the very end sometimes when we have to give very huge doses. So it ain't pain, and it ain't simple. In Oregon, where they've now had legalized physician aid in dying for over 20 years, there have been some interesting changes, a high percentage of deaths at home compared to the rest of the nation. So all of the slippery slope concerns that one might think have actually not come to pass in Oregon. High rates of hospice referral before death, relatively strong opioid prescribing practices, and they are a leader in terms of commonality of do not resuscitate, do not intubate, recording, and across settings. It's also been a wake-up call for physicians in Oregon when you start giving training sessions on pain management before and after legalization of physician-assisted dying. I will tell you, when you give pain conferences, how to manage pain in states other than Oregon, and you take a look at who attends, it's by and large nurses. Maybe doctors are 10%. In Oregon, when they started, after Pulse came along and Aid in Dying came along, doctors started to attend the palliative care conferences because they thought, my interpretation is, they thought, if I'm going to have to do this, I better get better at providing basic palliative care. Now, it's actually now legalized in 6 states, and also the District of Columbia now has is under consideration. What will happen in Washington is anybody's guess now, but it's been legalized in Washington. So there's a lot of movement. So 1/6 to 1/7 of the population now has, probably about 1/6 of the population has legal access to physician aid in dying. So it's a changing environment. Here's the data from Oregon about how the practice has evolved since its origin. And you can see there has been a moderate increase in the frequency of cases that actually activate this. Quite a few more, about a third more prescriptions than actually people who take them. So about a third of people who get the prescription put it in their pocket. They're very reassured by it, but they end up not taking it. So this is just a little bit more data about the prescriptions. Again, 204 patients had prescriptions written in 2016. 114 of those ingested. 36 did not ingest, 54 unknown. And there were some people from the prior year who had their prescription in their pocket who ended up taking it in the following year. So again, they are able to track this. Now think about what data do we have from Michigan or New York about this practice, right? Bubkiss, right? We have nothing because it's completely secret. If you are doing this, you don't write about it, you don't document it, you don't get a second opinion, right? And we do know from older studies that there is a secret practice virtually everywhere, that good doctors, or maybe bad doctors, who knows, give a prescription to a patient or two within their practice, perhaps in their career. So additional data from Oregon, most of the patients are white, almost all had insurance, most had cancer, relatively well educated. They often had long battles against their disease, so they weren't shortcutting the process. 90% enrolled in hospice and all had access to hospice. So it wasn't the people who didn't have access. The folks who did this tend to have access to everything. Uncontrolled pain was not the main motivating factor. Loss of autonomy, lack of enjoyment, loss of dignity seem to be bigger factors. And it's been relatively stable, relatively low rates over 15 years. Now, what about Canada? Canada came almost out of nowhere last year, right? So the Canadian Supreme Court found a fundamental right to choose physician-assisted death that would include physician aid in dying, so doctors providing medication that the patient takes by their own hand, but also allowing for voluntary active euthanasia so that the doctor can actually deliver the medication. So a whole nother kettle of fish. And you don't necessarily have to be terminally ill, so the terminal illness boundary is not present in Canada. You have to have a grievous and irremediable medical condition that causes enduring suffering that's intolerable to the individual. That is a pretty broad law, right? Very different. And you know, we're just now, nobody knows how this is going to go. What kind of data are they going to get? But this is the law of the land now in Canada. And in Western Europe, particularly the Netherlands and Belgium, physician aid in dying and euthanasia have been legal for quite a period of time. The boundaries are soft around this, so it's not all just adults. Sometimes in competent children, sometimes in children over age of 12. In places like Germany, doctors are assessing patients but not delivering the medication, so that's another option because of their history of the euthanasia movement. So doctors are evaluating patients but not the ones who provide the medication. So again, this is a changing dynamic in Western Europe. So the current state of practice, what currently counts the most? Where you live. It's a good principled way to make decisions, right? The values of your physician. Well, that's what we want to have something count on, right? Whether our physician is willing to take a risk on our behalf or whether they're willing to prescribe. The willingness, and then the particular nature of your condition. What should count the most? Clearly the values of the patient should be the foremost in this process. The availability of hospice, because this really shouldn't be an alternative to hospice. Hospice is the standard of care for people who are dying. It should be for those cases where hospice stops working or the process is still unacceptable despite hospice. And then the values of the participating physician if they're going to participate. So again, physicians in all of these areas where it's legal do have an opt-out clause. So some key policy questions. Here are some interlocking policy questions. Clearly, we need to improve access to and delivery of palliative care services to all dying patients. Hospice should be the standard of care for dying patients. Palliative care should be part of the equation for folks who still want to have some ongoing medical treatment of their underlying disease. So that's the floor. And then once we have the floor, how do you respond to those infrequent but troubling patients who are dying badly despite excellent care? So how should we respond? It's fine to say no to physician aid in dying, but then how should we respond? Because I will tell you at a bedside, if you're a family member, you care about this question, right? If you're that patient, you care about this question. And say, well, doctors shouldn't do that. That's not good enough. That's not enough. You have to figure out how do you want them then to respond. And should we respond to individual cases underneath the radar screen or come up with individual creative solutions, or should we create public policy? What's a better approach? I think that's really the key, one of the key questions. So there are a need for safeguards to protect the vulnerable from error, abuse, and coercion. We want to make sure there's access to palliative care and that it's adequate. The risks cited, as Bob was mentioning, for physician aid in dying are also present for the other last resort options. Our people on life supports are our most expensive patients, right? And yet we do allow life supports to be stopped, even if people do say they're ready to die now. And we do that very forthrightly. Now, how do we do that? It's interesting. And across the country, well, we get our best minds together. We get palliative care consults. We get a consult in the specialty area of the patient's disease, and we document everything that we're doing. And you can go into a chart and find out exactly why that life support was stopped, because it's a big deal to do that. But we don't say you can't do it, and we don't force people to stay on life supports because it's hard to do. So the safeguards need to balance flexibility and accountability, privacy, and oversight. So the categories: palliative care has to be accessible and found to be ineffective, rigorous informed consent, diagnostic and prognostic clarity about the disease, ideally an independent second opinion by somebody who knows the disease and who is an expert at palliative care, and then documentation and review. So what are the risks of don't ask, don't tell? Well, it means that access is very uneven and unpredictable. It discourages explicit conversation. Don't take too much of this or it might kill you. What in the world is the doctor saying to me here? Is he giving me a green light to go ahead, or is he telling me not to? There's a risk of misunderstanding when we don't have very explicit conversations. So we want this to be not just be a vague conversation. This should be the most explicit conversation you ever have. This is a life and death conversation. There's no safeguards to ensure adequate palliative care and adequacy of evaluation. And again, if you are assisted in the secret system, you and your family, the doctor and the family and everybody involved has a big secret on their hands that they then can't talk about. So there's potential of bereavement problems. So what about the risks of being explicit about last resort options? It's going to frighten some people. If this is an openly available option, people might be frightened. What are these doctors about? Are they going to be ending my life in the ICU? It may lead to pressure to prematurely choose death, so there could be some coercion. It might undermine progress in hospice and palliative care, and it could undermine fundamental physician values. And I think these are legitimate concerns. So what are the advantages about it being explicit about all the last resort options? They acknowledge a problem. Patients like our patient here will have less fear that he's not going to be left on his own at the very end. It's going to free up energy, and again, in his case, to fight his disease, to get into the treatment process, to not be afraid. It reinforces the physician's imperative to be responsive. The non-abandonment value is, to me, extremely fundamental. Having somebody, if you all have somebody who's a medical partner who's in it no matter what happens, you are way ahead of the game. And if you don't have that, you're vulnerable in this process because it can be that some of the challenges are going to be difficult. We want people to get help if they need it. So if they're stuck, they don't know how to approach a certain thing, we want them to be seeing experts in palliative care. And again, in Oregon, most people want to talk and very few act. So the bottom line, physician-assisted death, and I would say similarly true for the other last resort options that we more or less agree as a society are permissible. They're only sensible in the context of excellent palliative care. They are currently unevenly and unpredictably available. I believe they should all be subject to similar safeguards. And in my opinion, open processes are more safe, predictable, and accountable than secret practices. Clarity about which options are available and under what circumstances would be beneficial because it would reassure those who fear a bad death, increased responsiveness to extremes of suffering, more ability to address unique circumstances, and more accountability when suffering persists. So now we'll return to our patient. So he went through multiple cycles of chemotherapy and spent a large amount of that time in the hospital. He had really almost every complication that is possible. He became septic, lines infected, all kinds of very challenging problems. And at the end of this, he had 4 cycles of very aggressive chemotherapy, and then we were going to see whether he was cured or not. And when we went to check and see if he was cured, he still had a good-sized mass in his chest. So he was in trouble. So before, because it was a rare tumor, we thought, well, what can we do here? So we called around nationally and said, is there anybody who's a real expert, like an international expert? And we found somebody in Indianapolis. Go figure. And so we sent him to see this guy in Indianapolis, and this guy, and I was on board for this. I was enthusiastic about it, but it really scared me because you can find enthusiasts on things in medicine, and that's not always a good thing to do. But this doctor really had a great reputation, and he said, what we really need to do is cut out the rest of it. And I thought, ugh. Okay, so I talked to all the people that I knew nationally about whether this was a good idea or not, and they all seemed to think this was a good idea. The patient was willing to go for it. And he then had surgery that removed this. He, again, had every complication known to humankind after surgery, and he ended up being cured. Okay? So I'm going to return and have you listen to him talk at the end of this process a little bit more.
And I thought more about the idea of hospice and the difference between taking my own life and allowing myself to be in the care of others at the end of life. And my thinking did evolve in some ways in that issue toward kind of softening my view on that, in that I would probably accept the option of heavy sedation or something if it ever came to that. If I knew that it would be done in appropriate and if I knew it would be done with dignity and not drawn out in any sort of lengthy way, that sort of option became less scary to me. I think as time has gone on, I've sort of allowed myself to entertain that option. Yeah.
So it became, at least, as long as your fear was that it would go on for a long time and kind of be undignified, and
right.
The reassurance came when you learned that it would be more, in some sense, more aggressive and
absolutely
had some time limits
absolutely
with it.
Absolutely.
Yeah.
The thought that it could be the time frame definitely was a major part, 80% of my thinking on that idea of heavy sedation at the end of life. I think in the idea that it could be more aggressive, it definitely softened my view on it a little bit. Yeah.
But you want to talk about? We also had to talk about sleeping medication and having some just in case for you. And
right.
How did that feel after we had that conversation?
Yeah. That my view hasn't really changed on that. That's something that I want for myself. I think I want that ability and control. I fear, I want that ability to make that decision for myself at the end of life. If life is no longer worth living, and my life has definitely, kind of played itself out, and it's clear that I'm not going to be living that much longer, I want to be empowered to make that decision. And the idea of having sleeping medicine on hand or something like that is a very comforting thought to me, that I, with my wife and whoever I've chosen to be there, could make that decision at any point, on a holiday or a weekend when no one else were around, if something kind of came to a head, some kind of issue came to a head, such that I realized that life were not going to be worth living any longer. But what concerns me about that option is that I might not be able to do it well. I might be, particularly in the situation I'm in now, I vomit so easily that I may not be able to take sleeping medicines well enough to induce death. And that concerns me about it. It's sort of an imperfect approach, and more final type approaches, more brutal approaches just wouldn't be my personality, But so I do have concerns about that approach. But the fact that I can have at least some choice and some control, even in the privacy of my own home, is very important to me. Even though I feel like the hospice option or the heavy sedation option might be even a better route in some ways. Having the control there's just a difference in feeling, a difference in the way I feel about my life, a difference in the way that my comfort level.
So this is 20 years ago. He's out in practice, doing well. So he really made it through. Whether that was pivotal in terms of keeping him going or not, who knows? But it clearly was an important question for him. It occupied a huge amount of his energy, and knowing that he could have an escape freed him up to focus his energy on other things. Could say he shouldn't want that, but again, I think you would have had a hard time convincing him he shouldn't want it. So with that, I think we'll stop and we'll take questions, right? Interaction? Yeah, thank you. Yeah.
Ask the question directly of one of our speakers. Just indicate by raising your hand, and one of the ladies will come around with a microphone. If you prefer to write your question legibly on a card in your folder, you do that, and just hold it up, and they'll also collect those, and they'll be brought down here when we have a bunch of them. If your question is to a particular speaker, please indicate that at the beginning of your question, and if it's to either one, make that clear. But before we get started with that, please join me in thanking both of our speakers for very stimulating and comments. Okay, the cards are coming up. Do we have a question for either of our speakers? That's surprising. I have one that I'll exercise the moderator's prerogative and put that, and I'll put it to both of you in sequence, and that is, you've both been writing and teaching on this subject for quite a while. Has either of you experienced a change of mind or opinion on this over the years of working with it and teaching about it?
I was more against physician aid in dying probably when I started than I am now. I still think, and I think this is someplace where we disagree, I think that it has the potential in American society to have that tail wag the dog. That is, if you look at the percentage of people who need physician aid dying versus who need palliative care, we in our society, and particularly in bioethics, like to talk about the hardest, most difficult, most unusual cases. And yet it seems to me as a society, as a matter of public health, we don't focus on what most people in America who have serious illness, who die, go through. And so as a matter of public policy, I would have rather spent a lot more time and energy debating how do we get good palliative care to all physicians rather than what I think was an aside that wagged the dog about physician aid and dying. On the other hand, I think I've become more willing to see, particularly as public policy has changed, that we need to do a better job in helping train clinicians to deal with these issues than I would have said we should have 15 years ago.
So out of residency, I became a hospice medical director as a piece of what I did. And you know, this was back in the days when hospice was just getting started, so we didn't know what the heck we were doing. So we were learning, we were just doing the best we could by the seat of our pants and learning as we went along. And to some degree, that's still true. There's not a huge amount of data here. But I do remember as a hospice medical director, if we had 50 patients, there was always one or two, despite our best efforts, that things were not going well. And we were racking our brains about how to respond. And we were trying to find ways to help them die better. And this is where we come to, you know, palliative sedation. We come to stopping steroids with people with brain cancer. We're finding all kinds of ways they could indirectly help them to die because they were dying really badly. And it was very distressing for everybody, families especially, staff. And so the notion, even though it's 1 or 2%, and I do believe that's maybe what it is, there's a lot of, that 1 or 2% has an enormous impact on a lot of people who witness that. So it's all that person's family. It's all the healthcare providers who've had contact with that. Talk to hospice nurses about tough cases. They will tell you about tough cases that'll make your hair stand on end if you have hair. You know, so I've always known there have been tough cases. Diane, the woman I wrote about in the New England Journal, that was the first case that I had helped in that way. So this was now, you know, 15 years into thinking the way I was thinking. So it's not that common. But I had talked to a lot of people about these issues, and I had helped a lot of people to die, and I knew I was helping them to die. And by the way, good hospice and palliative care doctors do this all the time. We find indirect ways to help people to die who are dying badly, right? Yeah.
And I think there is some advantage to the indirect.
I agree, except when it doesn't work, or when it's inadequate, or when people are challenging us in ways that Diane or this gentleman was. Would I have helped him if he was dying really badly? You bet I would. I would not have had it. Now again, it might have been through sedation. Most likely would have been, given the way because he would have been getting bad from a disease that was physically overwhelming to him. He probably couldn't have taken the medicine, but I would have found a way to help him.
Do you worry a little bit about the fact that if it was too easy, that a doctor who wasn't as dedicated as you were in looking at going to find an expert in Indiana would have said, well, you know, those other options are okay, much like the data in Japan that looks at palliative sedation and seemed to suggest that the doctors who knew the least about palliative care were the most willing to do palliative sedation?
Well, look at palliative sedation. We don't have to look to Japan for variations in palliative sedation. Look in Rochester or Pittsburgh. You know, you're going to find huge variations in how quickly people pull that trigger, and that does not have to do with patients. It has to do with our values. So my personal view is that the best protection against that is not to prohibit it or make it secret. It's to make sure that you require a palliative care consult if you're going to do this by somebody who knows what they're doing. Now again, in big places that's easier to do. As you get more rural, it's hard to do. There are issues with that.
We hope we've talked enough that now you have some questions.
Yes, I do have some. All right, so Dr. Arnold, this is for you. Most of your argument seems to be saying that the majority of interest in and the request for physician aid in dying are really requests for some other tool easing the process of death. If we set aside all of those misplaced requests, would you accept that the remaining cases are legitimate requests for physician aid in dying?
Well, I don't think there are any such things as any of this is about illegitimate requests, and so I would say, yeah, they're legitimate requests. They're legitimate requests for all sorts of things. That doesn't necessarily mean that one needs to respond to accede to those requests. I think that as a matter of ethics, that I am willing to say that in very rare cases, it is ethical for physicians to practice physician aid in dying. I wish we would have spent as much time writing and talking about all the 99% of cases and how to do a better job in those 99%.
One of the questions that is in a couple of these is to do with the Western value of control, and asks why it's so important that it trumps everything else. Hasn't that desire caused the slippery slope problem in the Netherlands? And how do you feel about the situation in the Netherlands?
Well, I mean, how many people in this audience are would you say, a little bit on the control freak side of the spectrum? Let's just have a quick show of hands. Seriously, have a show of hands. How many? Yeah, I mean, when people go into the helping medical professions across the board, they tend to be people who like to be in control, and they're trying to control death and other things by doing this. So the notion that people want to be in control of this process. Now we have, by the way, I don't know if this gets at this question, but we have also really monkeyed around with the dying process. When was the last time you saw a natural death? Okay, so what does that mean? Well, it means that I'm not opposed to this. I'm just saying it's got consequences. So we have learned how to keep people alive longer and longer and longer. Again, men on average to 80, women on average 85. That's average, okay? And I'm going to digress and talk about the compression and morbidity theory. So the hope was people would live healthy quite a bit longer, live sick a little shorter, and then die peacefully, right? Not the way it's going. Healthy a little bit longer, sick a lot longer, and at the end of sick, where often the wheels are falling off, and people are in trouble, or they've gone on so long that the stuff that has meaning for them has gotten so small that they're ready to call it quits. So that's going to be, is that an existential issue, or is that a physical issue, or is it a suffering issue? You know, it's very challenging. So I think some of this is of our own creation. That medicine, we've learned how to keep people going so long, and they're used to making choices along that way, and then this is one choice in that continuum in some sense.
And it's a societal problem in that we have an immense belief in medicine and in science to cure things, where the reality is we basically trade one disease for another disease a lot. We don't really cure that much, and it's clearly a problem in the last 20 years. I mean, until the 1950s, medicine had no impact on longevity of Americans. What has impact on longevity of Americans is social determinants of health, clean water, those kinds of things. And it's only been in the last 20 or 30 years, and yet we have an immense belief and trust that the next scientific advance is just around the corner that will allow us to make death optional. The head of my hospital is just become the head of my healthcare system has become quite enamored with immunology and the recent data from rats that if you give old rats, young rats blood, they get young, which makes me a little scared because he's got a lot more money than me, and although I'm not so young that I would be of help to him. But it is this sort of fantasy that Americans have, that death is optional. And we as a society and as a healthcare, we promote that. I mean, again, we did this study where we looked at advertising in cancer centers. And it's all about not quitting, fighting to the end, getting your miracle. And then it's no surprise that people, and this is, I think, more American than it is in other societies, have this belief. And so we have these tensions of control, and then if I can't get back to normal and they can't cure me, then I want to end it quickly. We have little ability, I think, to live with uncertainty and angst, and finding meaning in uncertainty and angst.
So that's a good segue into this pair of questions having to do with personal beliefs. Most major religions do not support suicide and physician aid in dying. Tell me your understanding of integrating one's faith in this issue. And the related question, have you studied people or treated those from Eastern religions who don't fight a disease as much as learn how to live in harmony with their illness? Do they use palliative care and hospice to the same extent? And do they also sometimes ask for aid in dying?
So I'll give this a try first. I mean, there's no simple answer to this, right? So you take a look at a Catholic theology and you say, well, there's no way a Catholic is going to want this. And then you survey Catholics, right? And surveying Catholics, they're an imperfect bunch, like the rest of us. And about half of them would like to have access to this. So again, it varies a little on the survey. So and then you took a different religions have different takes on this. So Unitarians, for example, now you could argue as Unitarian. I'm a Unitarian. So is that really a religion? But that was a joke.
They believe in it most ones.
Yeah. Or Buddhists, for that matter. Buddhists are open on this issue. So there are religions, and what really counts, in my opinion, is the religious beliefs of the particular patient and the particular physician, if the physician is going to help. So that's really what counts. So the patient's values count the most, right, and their religious beliefs. And if somebody was a Catholic who was asking about this, I would ask them about how do they make sense out of this, given Catholic teaching, and they would teach me how they made sense out of it. Now again, if I were a Catholic physician or a religious physician who thought this was something that was not permissible, that I couldn't live with it, I would not provide it. Now what would I do? I would try to find other options, and I do that anyway, like sedation or other things. And then if I couldn't find common ground, I'd refer him to Bob, and Bob would struggle with it. I'd do something like that.
I have to say, I know of no data that looks at Eastern religions and their attitudes as a population-based issue. I have to say that my clinical experience is that what it says their religion is and what their spiritual beliefs and hopes are do not correlate very highly at all. I take care of a lot of people who believe that they will go to heaven and yet are willing to go through lots of things to keep from going there as long as humanly possible. And so to think that there's this simple relationship between one's religious beliefs or what the doctrines tell you should do and what happens when you sit down as a clinician and a patient, I think, is, as Tim pointed out, is just, it doesn't work that way.
What does count, I will, those of you who haven't done this, having a conversation about how people have died in your family is really a worthwhile thing to do. And going back in the family tree and I will tell you that bad deaths where people died suffering in serious ways have a huge impact on families and how they think about this issue and how they approach the end of their lives. So that bit of history taking for each of us and for our patients is a really useful thing to do.
Well, both of you have accompanied a number of patients on the journey to the end of their life. Would you comment on whether, in your opinion, a patient can be wrong in judging how much physical suffering they can actually bear? And is the same true about emotional suffering?
Bob?
Well, so I think that we often can be wrong about what our futures will look like and what we're able to go through or not go through. And I don't think we have to look at death. All we have to do is look at childbirth. Many people, and it's unclear which self we should listen to, right? So you're an OB, you talk to a woman who says, I only want a natural birth. No pain medicine. So now she's in the middle of labor, and she's willing to sell her husband for an epidural.
Too late.
So you do the epidural, and then you go back to her, and she says, I wish you hadn't listened to me. So I think it's really complicated to know what, quote, real beliefs are and what's true. I have a lot of people who go through things and find meaning in their experience that they never would have thought they would find meaning in, are willing to put up with suffering because of positives that they never would have expected. And I've had people whose families are like, he doesn't seem or she doesn't seem able to go through this in the way that I would have thought. That people who have pain, who seem to be doing well with pain, and then you tell them they have cancer as the cause of their pain, and their pain gets 30 times worse. So yeah, I'm surprised, and it seems to me that my surprise to a certain extent doesn't matter. What matters is where they are in the moment that I sort of contact and talk to them. I don't know what you think.
Yeah, the whole dissecting out suffering, that how much is existential and how much is physical, and my observation of suffering is that it's kind of a blob that is a composite of all these things, and even though I do believe it's worthwhile trying to tease it out, because there are pieces of suffering that we can fix or address or try to ameliorate, and that's really worth doing. But I think the part of suffering I feel most confident about is pain and shortness of breath and even nausea and vomiting, even though we don't have very good answers for those things, because I sort of have a way of thinking about those. But my patients, it's often a real mix of sadness, despair, hope, frustration, and being with people and listening to them is the name of the game. I would say the more it's on the existential, spiritual domain, the more I feel like, as a physician, I'm out of my depth. So if it's predominantly in those areas, and somebody's talking about wanting to call it quits, I got to get some help. So I will find my best chaplain, or somebody from their tradition who I really trust, who's not afraid of these questions, or or a really good psychiatrist who's not afraid of death, and that's not easy to find sometimes. Any psychiatrists in here? Yeah, no? Well, it's true, right? I mean, just like the rest of us, right? But some psychiatrists are really able to get into those issues, and they really that's okay with them. And for that patient, you really need that person. So we're really trying to unbundle it and see what can be fixed and what can't. And then but ultimately we're really trying to listen and have them really teach us what's acceptable to them and what's not.
So this next series of questions has to do with the legalization of physician assistance in death, and asking you to speculate on the future trajectory of it. Do you see any national adoption of this movement with the success of it in the 6 states that have adopted it? What's holding it up from moving forward more quickly? And a related but sidebar question, do you believe that if it gets legalized, it will lead to the disincentivization of research into debilitating diseases that lead individuals to opt for this choice.
I'll let you go first.
The processes of legalization within states are incredibly varied. So I think in states that have strong referendum processes, where it's the will of the people, I think there's a reasonable chance you can have movement in those areas. In states where it's legislatures having discussions like what we're having nationally right now, I think it's completely off the table. It's way too easy to demagogue this issue. And we got demagogues in all parts of the world right now, trying to have, and they're not able to talk about sophisticated things like this. You have to have people who are really willing to suspend the demagoguery and talk about what's meaningful, and that's not going to happen. Referendum places, I think things can happen, but most of those states have already had a referendum, so there aren't that many left. Again, and then you can have case law. You can have a particular case that might go and try to do case law, and I think that's not going to happen either.
Well,
So,
I think that would be a mistake. I think for the Supreme Court to make it a right and short circuit the referendum process or the process of individual states making decisions, I think has a very high risk of leading to a backlash, both about physician aid in dying and about palliative care more generally, because of the demagoguery issue. And I would think that would be not a wise way for public policy proponents to proceed.
yeah, we're in total agreement about this, by the way. I totally agree. First of all, the Supreme Court, I don't even want to think about them taking on this issue right now. But even if they did and they decided it one way or the other, I mean, basically the Supreme Court did decide this issue, right? And there was 9-0, basically saying we're not going to set the law of the land, but we're not going to interfere with states.
Right.
If states want this, they're going to have it. Now, if you get to where we got to a less controversial issue than abortion and assisted dying, marriage equality, right? When you start getting 2/3 of the state that allow that, then you have another Supreme Court question. But it's not until that happens, and we're a long way away from that. That's decades away, I believe.
How about within medical education itself? Are you seeing a shift toward palliative care as a focal point of emphasis?
So there are two things. Someone asked about whether the NIH should spend less money trying to treat diseases because of physician aid in dying. No. That isn't the way the NIH works. The NIH will spend less money if the budget changes and they have less money. Otherwise, they're going to spend the money they have because the NIH is made up of scientists, and the role of science is to try to change what currently happens in the world or understand it. I think medical schools are becoming way more interested in doing teaching, and nursing schools and social work schools about palliative care. That isn't to say that there isn't much more that could be done, both about symptom management and about communication processes. I think that because California has a physician aid in dying law, I think many more medical schools, even if they're in states that don't have such laws, will do some teaching about this because so many residents end up going to California because it has so many of the residencies. I think the open question is, how do we change what happens once you're out of medical school and in residencies and fellowships and practice to set up environmental structures that promote palliative care? And I think that's a bigger societal issue, and it's very hard to know what's going to happen with that given all the controversies that are ongoing about health insurance in this country, or the ones that I've been reading about.
So here's
This is a bit of a digression, but If we could double the number of palliative care doctors in the country right now, we could probably find jobs for them, right? Because palliative care is a growth industry. So palliative care is on the map. The problem is there are not near enough palliative care clinicians to take up the jobs and the opportunities that there are. So basically what we're going to have to do is train good doctors to do the basics of palliative care. And Bob and I have talked about this a lot, and we're totally on the same page about this.
It would be better if we didn't call it palliative care. If we would just call it practicing good medicine for seriously ill elderly adults. Because the problem when you ghettoize it by calling it palliative care, then people say, well, we'll just send it to the palliative care specialist, and that'll never solve the problem, or it won't solve it by the time that I need it. And that's what I really care about.
So it might be that a lot of the audience is not really familiar with palliative care, palliative medicine, and a couple of the questions reflect that. There have been a few comments on the need for a palliative care consult in relation to a PAD request. What do you hope to glean from the palliative care consult?
Well, it's pretty clear. First of all, you want to make sure that you understand the reason for the request, right? What is the reason for the request? So if it's pain, let's say it's pain, the easiest scenario, then you'd want to make sure, are they getting the best possible pain management? So you'd want to make sure whatever management they're getting of the problem that's the main driver for this, that the management is optimal. And then you're also going to ask the question, are they depressed? Are they thinking clearly? Do they have a clear diagnosis that they understand? So there are some questions about how their understanding of what's going on. If they're depressed clinically, maybe we should treat their depression. So again, a digression. I saw a lady on psychiatry who wanted us to stop life support. So it wasn't physician-assisted death, but she was on several life-sustaining therapies, and she was profoundly depressed. I said, look, we can't. I made a deal with her. I said, let us treat your depression for a month, and if you still want to stop, then you can stop. She was on dialysis. What she was on, she wanted to stop dialysis. And we treated her depression, and she didn't want to stop dialysis. So there's a lot of room for careful assessment that should be part of this process. That's why, in my opinion, bringing it out of the closet and out in the open is so important, because you really then... Now, there will be cases, if we bring it out in the open, where people are saying, I'm done, I've had it, and you need to listen to me. If we don't mind hearing that, then we should bring it out in the open. But it will... Most of the time, we'll be able to find palliative care options, I think.
Well, I think that we need, part of the problem is that people don't like having these conversations. And some of you might be saying, well, it's just talking to patients. How hard can it be? And yet the data that's out there about clinicians talking to patients is that we don't do a very good job in having really emotionally difficult conversations. And there's no reason to believe that physicians should know how to do it just because they're physicians, because they're topics that are a little, that are emotionally hard. They require you to be able to sort of probe more than we often probe. And so it's the kind of thing that if you don't teach people how to do it, they'll never do a good job. I would argue that regardless of what we do with physician aid in dying, we need to teach people how to have these conversations, because that patient was lucky that they saw Tim Quill at University of Rochester. If they would have been in many other places where there wasn't a palliative care doctor, that's a conversation that their nephrologist should be able to have with them, or their primary care doctor should be able to have with them. And one of the things, again, that's sad is in our society, we spent way more time and energy focusing doctors on how to give pills, partly because it's quick and it's easy and it's remunerative, than we do in teaching them to have really tough conversations.
And let me just digress for one moment and turn the tables on you all. Think about within your own families, whether your parents or grandparents or children or whatever. Have you had these kind of conversations, right? If not necessarily the assisted dying conversation, the what would you want if you got super sick conversation, the advanced directive conversation. If you have not, you are contributing to the problem.
Right. Or even worse, if they come to you and they say, I want to talk about what if I get sicker, and you say, oh, you're doing fine. What do you mean talk about when you get sicker? Let's go out and do something. Let's go bowling. Well, but it's the kind of thing that when people come to us, our immediate reaction is, ooh, why do you want to talk about that? I mean, let's talk about something non-controversial, like what's going on in Washington.
We have a question about how do you approach these decisions with parents of pediatric patients, both those who are mature minors and those who are too young?
Well, if you think, we have a hard time having these conversations with our 90-year-old grandparents, right? So think about a 9-year-old or a 9-month-old or a 9-day-old, and you almost don't even want to imagine it, right? Because it's got to be so freaking hard. When we started out with our palliative care program, we didn't have a pediatric separate program, so we did it because nobody else was doing it. And again, from a decision-making point of view, the details of symptom management of palliative care, like I was really flying by the seat of my pants then with pediatric patients. But the decision-making part, although it was emotionally wrenching, it was similar decisions. But the little ones don't have any capacity, right? So you're trying. What's the ethical principle when people don't have capacity, right? You can't say, well, what would he want if he could understand this completely, because they don't have capacity. They never had it. So we're trying to figure out what's the right thing to do, what's the best thing to do, and it's really, really, really hard, and it really probably is going to turn a lot on the values of the family and how they see these things, and it's wrenching. As kids get older, as they get to be adolescents, we are going to involve them, and even though their parents have a say in this, we try to, particularly, a lot of kids who've been really sick, they're mature minors, and they need to have a voice in how much is enough and what they want to do, and the parents have to sort of go, they're in the game, so I think those are even more complex. But it's the same. These questions will come up for these folks, and if we do allow this for adults, will we allow it for mature minors? Because mature minors have certain kind of capacity. I mean, again, I think you can see in Western Europe they are struggling with this, and they do it on by and large a case-by-case basis. They're also, Western European countries are like super less litigious than our society, right? So they're used to trying to find common ground, using common sense and all that stuff that we've kind of thrown out the window legally. But I don't know whether what they're doing is right. Although, what do we do with these cases here now? It's not like we don't have them, right? So again, we muddle through and do the best we can. And it's not ethically clean, and it's not legally clean.
Nothing to add. How do you respond to a patient who is concerned about their future pain or suffering and wish to address the option of assisted death before they lose their personhood?
Yeah, I think that one of the questions I have, a couple things go through my mind, which is there are some people whose sort of personalities are they want to cross every bridge before they get to it. And sometimes just mentioning the fact that I wish we could be in control of everything and pointing that out to them is helpful because it allows them to take a deep breath. And so we can talk, I'm more than willing to talk about XYZ option. I sometimes worry that talking about every option down the road distracts them from being able to appreciate where they are now. And so part of what I would think in those cases is, while I want to deal with that, I want to also sort of see the enjoyment and meaning they're getting out of their life now, and I worry a bit about people who are trying to cross every bridge in a controlling way to cross what happens 150 miles from now, when we probably can't even control right where we are. So, some of it is just to have a discussion. Some of it is to make a commitment that you're going to be with them 150 miles from now, that if the going gets tough, that you're not going to sort of stop coming and seeing them or stop caring for them or stop appreciating them. And so some of what you're doing is, in fact, making a pledge of non-abandonment, and sometimes that's helpful. Some of what I can do for some of these patients is to give them things to read, because more information is helpful for them. Other people who worry a lot about the future, in fact, giving them more information to read about all the options just makes them more anxious. And so some of it is trying to figure out what helps them cope the most in the moment, and then seeing if I can provide that for them.
So think about the young man that I presented earlier, and he wanted a commitment that if his suffering got horrible at the end, that I was going to help him to die. Okay, and he didn't need a prescription in hand; he needed a commitment in hand, and he really wanted that commitment, and I gave it to him. Now, what was I going to? I was committing to helping him in any way that I could at that point. And I said, I'll be as creative as I can. We don't know what's going to be happening, but that's the funny thing, the odd thing about the current environment is that we've created an environment when doctors are faced with that question, they often say, oh, don't ask me that question. I don't want to deal with that. I'm afraid to deal with that. It feels too dangerous. Doctors don't help patients to die. Right? Doctors do help patients to die. Right? We do help patients, because all of our patients die if they care for them long enough, and we try to ease it as best we can. So what he wanted was a commitment to help him find a way out that would work for him if he got into a bad situation. That's the thing. And I believe that if I were a doctor who was adamantly opposed to Aiden dying, I could still say to him, I will do my best to help you find a way out. Now, again, it might be sedation, it might be stopping eating and drinking. I don't know what it's going to be. And we don't have to get into the specifics, but he would need to know what I can't do as well as what I can do. But more what I can't do if that was important to him.
It's the commitment and the being willing to sort of witness with him the future that, in my experience, is more important than the details of exactly what you'll do or what you won't do.
But if you make that commitment,
you got to keep it.
You got to keep it. That's because if you make that commitment and you don't keep it, that's like the worst. It's being a bad person. It's worse than being a bad doctor. It's being a bad person, because if you make that now again, doesn't mean you do things you can't live with, because you don't do things you can't live with. And if that ends up being the pivotal thing, then they need to find another doctor, because if you can't live with it, then you can't live with it. And you don't do things you can't live with.
Well, thank you very much, Dr. And to the public or the others in the overflow room or in our distance sites with any questions for our two panelists? Yes, sir.
Last point, I think that was really good. I think you were saying that it's more important to say what if a doctor can't do one thing, they should tell that patient, I'm going to do everything I can, but really I can't do this one thing. So it's more important to say what they can't do if that's a question.
Yeah, I think it's important to say it. I don't think it's important to lead with it.
Oh, for sure.
I think that in the end, when all the talk is done, if there are things that I just can't do, I need to stress mostly what I can do. And then I need to acknowledge that there are some places that I as a person, not that there's anything wrong with their request, but I as a person can't do.
Well, thank you very much for a most stimulating evening. Please join me in thanking our two speakers, Dr. Quill and Dr. Arnold. We did have one question about whether a copy of the presentation will be available. The tradition has been that the DeVos Colloquy is turned into a monograph. It's been recorded, so there'll be a verbatim transcript of that, and you can arrange for a copy of that by contacting the leaders of tonight's program. Dr. Nagelkirk?
We've changed that, and it's going to be on the website.
Online.
So you can go to the website, the Vice Provost of Health website, and the transcript will be there.
And how long will that take, Dr. Nagelkirk?
That usually takes at least 3 months.
3 months. So check back in 3 months, middle of the summer, and look for tonight's presentation, including the slides.